I am going to share altogether a different type of lecture, okay. That is secrets of success in endoscopic sinus surgery, okay. So what I am going to tell you, there will be a lot of repetition of what we already said last 2 days, okay, and also in the same slides lot of repetition, but remember repetition is mother of learning. You more you want to learn, you should repeat more, okay. So I want to play this small video, just watch this video. Yeah. So what message I want to convey with this video is, now the world is full of competition. If you want to survive the competition, you should be the best. We as professionals, professional ENT surgeons, we should be the best in whatever we do. That is the message, okay. And coming to the factors influencing the results, everybody wants to be successful in surgery, they want, but what factors they matter is the surgeon factor, patient factor, primary pathology, anesthesia, equipment and surgical technique, everything matters, okay. Starting with what surgical surgeon factors matters is surgeon's attitude for continuous learning. We see so many workshops in Bangladesh itself, that itself shows that how much important for us continuous learning and getting a good training and our attitude to learn. That's what is very, very important. Being open to ideas. We always start at this stage where you say, whenever we come across something new science, we say I won't do it because it is difficult or something. Or then we say, if somebody asks why you are not doing it, because I can't do it. But we always have a wish, I want to do it. Then you ask people how to do it. Then you will say, I know how to do it, I will try to do it. Okay, I will try to do it. Then you have a moment, I can do it. I can do it. In the end, you come out flying, say, celebration, I did it. Excuse me. Each and every one of us always in some stage of this surgical steps, okay. You have to identify in which stage you are at this right moment, and then you should progress to reach this stage, that is I did it, okay. Very important. So training, what type of training we need? We need a 360-degree training. So how to do 360-degree training is, you should always start with strong theoretical knowledge. If you attend one workshop, not enough. If you see one surgery, not enough. But before you start anything new, you should have a strong theoretical knowledge. You should read all the books possible. Why I tell this is because eyes cannot see what mind does not know. When you start operating, if you don't know all the possibilities what you can do, you have no ideas. For the morning, for example, we didn't have an idea to take costal cartilage, we didn't know what to do. We were lost, we didn't have any plan. But as it went on evolving, since we knew this is the possibility we can do, we could do it, okay. Like that, before you start, you should have a strong theoretical knowledge and always try to get hands-on cadaver dissection. There are wonderful courses which are being organized in a very, very discount price. Attend those courses, attend live surgery workshops, and if you want to be a good endoscopic sinus surgeon, do frequent DNE. Patient cannot afford, do free DNE and attend workshops. That's what is important. And I said vast theoretical knowledge, eyes cannot see what mind does not know. What should we read? Read original papers, mainly the meta-analysis papers of each and every entity, okay. And develop parallel knowledge, review articles you should read, and the monograms, the single author books, they carry lot of experience by that author, okay. And coming to the parallel knowledge, anatomy, you should always have a strong based anatomy, particularly here when you are dealing with endoscopic sinus surgery. You should have knowledge about neuroanatomy, vascular anatomy, that's the blood supply of the nose paranal sinus, ethmoid infundibulum, middle turbinate, frontal recess, anterior skull base and sphenoid configuration. Everything you should know, okay. Okay. And one important anatomy, if you want to prevent complications, avoid complications, is you should know how to identify the anteethmoidal artery. You should try to identify anteethmoidal artery on CT scan before you start surgery, whenever ethmoidectomy is involved. There is one clinical sign, it is called bird beaks appearance or nipple appearance. You can see particularly whenever there is supraorbital ethmoid cells well pneumatized, you will be able to identify. You can see this is anteethmoidal artery, where from anterior cranial fossa it comes to the ethmoid and enters the orbital cavity. Okay, identify this sign, that is bird beak appearance. But endoscopically, how to identify is this is ethmoid crest. This is nothing but superior attachment of the anterior wall of the ethmoid bulla. This one, ethmoid crest. In front of the ethmoid crest is the frontal recess, and 2 millimeter behind we have anterior ethmoidal artery, which you will be able to recognize. Okay, always remember this. And also frontal recess, you should remember anatomy very well. It is in the frontal sinus, lot of surgeons have problem. Always remember the anatomy. And this is a sagittal section which is showing here the nasion, and this is the antemost ethmoidal cell, that is agarnaceae, and this posterior wall of the agarnaceae becomes anterior boundary of the frontal recess. This is the frontal sinus and this is the frontal recess. Here is the ethmoidal bulla, it is the anterior wall of the ethmoidal bulla which becomes posterior boundary of the frontal recess. If this anterior wall deficient here, this frontal recess directly open into this supra bullar space which we call all lateral sinus of Grunwald. It is communicating with the frontal recess. So any disease here in the lateral sinus can again give rise to frontal pathology. Here on a coronal section, you should be able to identify again the frontal recess here. Here what happens is the medial boundary is the middle turbinate, and the lateral boundary is this the lamina praeparatio, and also part of the uncinate, depending on where the uncinate is attaching. If the uncinate is attaching here and the lamina praeparatio, then the medial wall of it becomes medial boundary of the frontal sinus. That you should remember. And the middle turbinate attachments you should remember very well, because if the anatomy of the middle turbinate becomes clear to you, then it becomes everything is easy, because there are three parts for the middle turbinate. The part 1, which is vertical part, this attached to the anterior skull base. Part 2, that is the oblique part, okay, or the middle part, this is attaching to the lamina praeparatio. This is the middle turbinate, this is the ground lamella or attachment of the middle turbinate we call. And the third part is the horizontal part, this is the middle turbinate, it is attaching to the vertical plate of the palatine bone. That you should remember. Anterior skull base configuration, you should remember. See, anterior skull base, the anterior part is high and thin. This is the anterior part of the skull base where you see middle turbinate attachment. This is usually high and thin. But as we go back on the posterior ethmoids, here it becomes low and thick. You should remember that it is low and thick. What is important is the anterior skull base, you can see it is high and thin here. As we go back, it is low and thick. It is at the junction here, the oblique part, where the high and lower part is there. This is where we tend to lose our depth of sense of perception, and we tend to injure the anterior skull base here. But if you have this knowledge, this becomes very easy. You can see anteriorly it is high and thin, posteriorly it is low and thick. Remember that. And also anterior skull base, remember Quiros classification which has been shown already. Okay, that depends on the height of the lateral lamella of the cribriform plate. Okay, the cribriform plate has two parts. The cribriform plate has two parts. This is the lateral part, this is the medial part. The medial part is the one where the fibers of olfactory nerve come out. This is the lateral part. Here this is very thin. This is 1/10 of fovea ethmoidals. That's about 0.1 millimeter. Okay, depending on height of this lateral lamella, this is divided into three parts. If it is about 1 to 3 millimeter, it is Quiros 1. 3 to 8 millimeter, that is Quiros 2. Above 8 millimeter, it is Quiros 3. It is the type 3 which is very, very dangerous. Coming to the sphenoid configuration, you should remember the types of pneumatization: conchal, precellular, cellular and postcellular are there. Here this is a conchal type where only a small air cell is there. Small air cell of the sphenoid is there. You can see this is a X-ray showing small sphenoid air cell in front of the cella, and this is the precellular. Here it is below the cella and anterior to the cella, and if it is cellular or postcellular, entire sphenoid is very well pneumatized. This is important because nowadays ENT surgeons are slowly getting into anterior skull base, so they should remember this. Parallel knowledge, what parallel knowledge we have to learn is, we should learn how to read the CT scan. Okay, that I am going to do that small lecture to you after this. So you should know how to read the computerized tomography, Also to understand the pathology, microbiology and some of anesthesia. You can't rely everything on anesthetist. You have to learn some of anesthesia yourself. Okay. Computerized tomography, you have to learn normal anatomy, anatomical variations as well as pathological conditions. And if you are interested, I have a written book in 1997, Imaging for Endoscopic Sinus Surgery, a handbook. It is there on our hospital website, free. Anybody can open it and write it. The website address is thekenthospitals.com/IESS. You can go and access this book and read how to read a computerized tomography of the paranasal sinus. And when you study the computerized tomography, yesterday also Professor Rashid, he emphasized about this. That is, what you need to study is close the gaps in your mind about the paranasal sinus and anti-skull base. And in that, C stands for cribriform plate, lamina propria. You should study in each and every section and noddy cells, skull base and sphenoid, and anti-ethmoidal artery. I have shown you how to identify anti-ethmoidal artery. Coming to the patient factors, you should remember this also very important, as it will reflect on your results. The one is patient education, how educated he is the general health, what are the limiting factors, and reliability for follow-up. Okay. The local factors, if there is acute infection, it's going to be troublesome surgery, lot of bleeding, you have to treat that, and there may be inflammatory process and granulation diseases you should address, you should understand, and there may be excess local tissue trauma during dissection, and appropriate course of antibiotic may be required in these cases before you proceed. Systemic comorbidities you need to assess, particularly elderly patient, that is hypertension, peripheral vascular disease, liver and renal diseases, chronic alcohol abuse, malnutrition, vitamin deficiencies, which particularly vitamin K, which may give rise to bleeding diathesis. Okay. And bleeding diathesis, you should rule out hemophilia A or B or von Willebrand's disease, or if patient is receiving medications and affecting the surgical fields, particularly if he is receiving aspirin, NSAID, warfarin, antiplatelet agents, or some herbal medicines like ginseng, ginkgo and kava. You should consult the consulting doctor who is giving these medicines. These medicines may have to be stopped 1 week or 21 days before the surgery. Okay. And if patient has von Willebrand's disease, you may have to give clotting factor replacement or desmopressin, or even you can use tranexamic acid or aminocaproic acid. Primary pathology, so again the results depends on acute or chronic, complicated or non-complicated, allergy or infection, inflammatory or neoplastic. We know that whenever there is acute infection or inflammatory pathology and non-complicated, it has good results, whereas chronic, allergic and neoplastic complicated have bad prognosis. So we should be very well aware about it. Again, when it comes to pathology before endoscopic sinus surgery, you should understand whether it's a bacterial pathology or fungal pathology. Okay, that you should be able to differentiate. If it is fungal pathology, you should be able to differentiate between allergic fungal rhinosinusitis with invasive sinusitis. Okay, this is one differentiation you should make. In allergic fungal sinusitis or fungal pathology, what you find is double density appearance on the CT scan. Yesterday, which case I operated, I showed you. Coming to the equipment, see, we should have a good equipment, endoscopic sinus surgery. So now we have advanced HD high definition cameras available. So we should always invest and reap and never compromise on this equipments. And also, whether directly you want to view or you want to view camera or into the monitor, it's up to you. But whenever you do this, always innovate. Okay. Coming to anesthesia, see, there was some discussion yesterday why we should do local infiltration in all surgeries. Okay, use GAR LA judiciously. Some of our surgeons are doing endoscopic sinus surgery under local anesthesia also, but my advice is don't be dogmatic. Okay, use whichever anesthesia you want judiciously, but infiltrate local anesthesia even when you operate under GA, because in our country we have a lot of variation of anesthetists. Okay, I identify anesthetists as 4 types. One is the best anesthetist you can get, and the remaining 3 types, one is superficial type. See, these anesthetists, what they do is they keep plane of anesthesia very, very superficial. So even though patient may not be moving, patient will be having pain. If patient has pain, that will activate adrenaline mechanism, that will cause bleeding. If there is a bleeding endoscopic sinus surgery, it will interfere with your work. The second type of anesthetist I call gas man. That is, they use lot of inhalant anesthetics, like all these gases, pethidine, isoflurane and things like that, and these gases cause vasodilation and lot of bleeding. Okay, the ideal anesthesia for endoscopic sinus surgery is intravenous anesthesia. Okay, and the freelancer we have in metropolitan cities where they run from one hospital to the other hospital. So what happens is, even before your surgery is completed totally, you find that patient is already moving, is already in the process of bringing out the patient from anesthesia. So again, this is a dangerous type of anesthetist. Okay, and intra hemostasis, I told you how to control is have a total intravenous anesthesia and only avoid only inhalation anesthetics. Okay, avoid inhalation anesthetics, and end tidal carbon dioxide should be between 30 to 35 millimeters of mercury, and the head of the bed is always elevated 15 degrees, and mean arterial pressure is between 60 to 70 milligram, okay, millimeters of mercury. That's what you should demand your anesthetist. Okay, that will give you this thing. Coming to the surgical technique, remember FESS is all about minimally invasiveness. First, do no harm, a primer no theory we should remember, and do only what is necessary, and we should not venture into the areas where there is no pathology. We should not dissect mucosa or tissues unnecessarily, and do not disturb the normal anatomy. Okay, and surgical technique, always plan, very important. And whenever you operate always on a patient 7 times. Okay, and always keep a logbook, personal logbook. Whatever happens, you write in your personal logbook what went wrong, what wrong you did, what good you did, and when patient comes back, follow up, you assess with that background. Okay, and always divide and rule. Japanese says, if you have a big task to achieve, what you do is cut the task into small pieces and achieve one by one, solve by one. Same thing in the endoscopic sinus surgery, you know that you have to do a big procedure. What do you do that? You cut down that procedure into small steps and go performing one by one. You will be performing better, and be flexible when you want to do it. Plan, I said, surgery is all about one landmark to the other landmark, and you always address the disease in between these landmark, and always try to find the structures, do not discover, and be minimally invasive. I call this as a flight plan. How do pilots fly from one area to the other? They don't fly in a direct, in one direction on a straight line. They always plan in such a way that they go via one airport to the other airport, so that if there is any emergency, they can land in one particular airport whenever possible. So they don't fly in a straight line. Same thing in endoscopic sinus surgery. You always go from one landmark to the other landmark. I would say the 10 commandments in endoscopic sinus surgery is, you start with pre-op imaging assessment and optimize the surgical field, use appropriate whatever decongestion is used, and do a proper uncinectomy. If there is atelectatic consonant process, you should be careful about it. If you don't address that properly, you will enter into the orbital cavity, and the ground lamella penetration always in the oblique part of the ground lamella, that's the middle part of the ground lamella, and find the landmarks and safely remove the bony septations little by little. Okay, and thorough but safe along skull base, you should be very careful. And if you want to open into the maxillosinus in canine fossa, do an endoscopic assisted canine fossa trephination and ensure proper hemostasis. And if you fail to plan, remember you are planning to fail. Okay, and prepare surgeries. You have to prepare pre-op preparations, do properly, and prepare for intra-op preparations properly, and prepare to handle intra-op bleeding. You should be ready. Pre-op evaluation, it depends on local factors, systemic factors, bleeding diathesis and drugs. Okay, I told you about those things. Intra-op preparation, time spent on preparation saves surgical time. Remember, give a good vasoconstriction. Now we are using in 30 ml 4% xalocaine, sometimes as much as 30 ml of adrenaline. It doesn't harm. It never gets absorbed so much. The initial adrenaline itself, it causes so much vasoconstriction, it prevents further absorption. So don't worry. So use good vasoconstriction, and when you are packing, do a gentle packing. I use Merosol. That way, while packing itself, it should not be causing injury to the mucosa, and always use non-traumatizing packaging material like gel foam, and have patients wait for about 8 to 10 minutes. Okay, and for intra-op hemostasis, what you can do is, we use tranexamic acid intravenous injection, about bolus 15 milligram per kg body weight to start with. Then we use an infusion of 1 milligram per kg body weight per hour for the duration of the operation. This gives a very good bleeding control. And decongestion of the nasal mucosa, initially with oxymetazoline drops you can put before shifting to the OT, and subsequently with nasal pledges soaked in 4% xylocaine, 1 in 1000 epinephrine. Okay? And bilateral sphenopalatine blocks sometimes we give with 1% xylocaine and 1 in 1 lakh adrenaline. Okay? And I told you one landmark to the next landmark. What we should do is we should do an infundibulotomy. When we do that, identify the middle turbinate and uncinate, do a proper uncinectomy. Then the frontal recess, you identify agarnaceae and antiva bulla. Okay, yesterday I showed you how to go with the intact bulla technique, and if you want to do middle metal antrostomy, you identify the floor of the bulla and inferior turbinate. It is between these landmarks you do the middle metal antrostomy. Be minimally invasive. Okay, God has a purpose for each and every tissue, and be meticulous but gentle, avoid mechanical force, and good quality sharp instruments you must use, and use non-tearing instruments. Don't tear, cut. Okay, I told you when you operate on every patient, you are operating 7 times. This is very important philosophy which I have developed in my life. That is, when you clinch the diagnosis, the moment you have seen the CT scan, and the moment you see, you should run the complete plan of surgery in your mind. That is the first time surgery you do. And when patient comes for admission day before the surgery, you run the whole plan again in your mind. That is the second time surgery you do. And while you are scrubbing just before the surgery, you just close your eyes and imagine the entire procedure you are going to do. That is the third time, and actual surgery is the fourth time. Okay? And try to record those surgeries, and during follow-up again you see that surgery, and again you assess what happened. That is the fifth time surgery. And what you are doing, don't try to hide and keep it for yourself. You call the other surgeons, you go demonstrate surgery, call everybody what good work you are doing, show them. That is the sixth time surgery. And whatever you are doing, you accumulate the database and you present and publish in peer-reviewed journals. That is the seventh time surgery. This is my philosophy. Okay? And always keep a secret logbook. This is very important. Record mistakes in bold, record surgical steps, review during follow-up, and learn from mistakes. Okay? And divide and rule, I said, you always go one step by one step. Start with uncinectomy, then a frontal recess clearance, intact bulla technique, then do a middle metal antrostomy while the bulla is still intact. It is easy. Then you do the anti-ethmoidectomy, post-ethmoidectomy, and sphenoidectomy. I showed you yesterday how we go step by step. And the risk factor, the various risk factors are there. General anesthesia itself is a risk factor. For the right hand surgeons on the right side, left hand surgeon left side, there's always a risk, and lack of surgical experience. Try to get more surgical experience. If there is an extensive disease, you should assess before. That's a risk factor. And excessive bleeding and revision surgery. These are all risk factors. Identify this risk factor to minimize your risk. And intra bleeding, if at all it is there, what to do? See that if there is any excessive local tissue trauma causing the bleeding. Okay, and double check that the patient position. Always keep about 10 to 15 degree high, and if I see anesthetic parameters are optimal, end tidal volume of the carbon dioxide is about 30 milliliters of mercury, and peak pressure is about, mean arterial pressure is about 65 to 75. You see that, and always don't suck the bleeding vessels. Okay, raw surfaces, if they are bleeding, don't suck on them. Use enough warm saline irrigation, and actively seek such bleeding sites and coagulate. And you can also use the free suction dissector. Okay. Common bleeding points are usually large branches of sphenopalatine artery or anti-ethmoidal artery. Identify, coagulate, or anterior face of the sphenoid sinus. There may be a branch of sphenopalatine artery, a sphenoid artery, and sphenopalatine foramen area. Sphenopalatine artery itself can bleed. And posterior rim of an enlarged maxillary sinus antrostomy. If you have done a very good middle metal antrostomy, the posterior edge usually bleeds there because the branches of sphenopalatine, and posterior end of the inferior turbinate, it can bleed if you are injured there, and also olfactory cleft near frontal recess, it bleeds more. So remember these points. And end of surgery, achieve hemostasis. If patient is under hypertensive anesthesia, ask the anesthetist to bring back BP to pre-op level, and do thoroughly suctioning of the blood, and inspect nasopharyngeal area. Ensure that there is no pooling of fresh blood, and bipolar suction cautery of bleeding vessels, you should do it if at all any bleeding is there. And be flexible. Do the same thing in many different ways. You should learn doing the same surgical steps in using different instruments, different methodology. Okay? Yeah. So that is what is a hallmark of a good surgeon. Sometimes you know, when we are operating in a different environments, we don't get the optimal instruments. We can't go on, you know, cursing, this is not good, that is not good, but we should be able to achieve the same, this thing with the different instruments, okay? And be creative and innovative and ultimately master what works in your hands best. Don't, you know, try to copy somebody else. Whatever he does, in which way you can do better, you should learn, and avoid monotony, and don't be dogmatic. Say this is what I'm going to do and only this works. There, I told you many things can be done in the same way, and update yourself. That is very, very important. Okay? Yeah. Thank you very much. That is in short.